Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me. I am a board-certified psychiatrist and expert psychopharmacologist, and I specialize in helping people navigate psychotropic medication trials. I am an expert at fashioning those regimens and helping a person get from point A to point Z safely and effectively with a minimum of side effects, as comfortably and with the least amount of displeasure as possible. And so please check me out on notonanemptymind.thinkific.com, my private online academy. The last video I did was on stimulant euphoria and how patients mistake the euphoria that they feel initially with that medication for the therapeutic effect. Patients don't understand that what they feel is actually a supratherapeutic effect. It's more than we need, but it's an inevitable consequence. A side effect that may be a welcome side effect, but it's not what we're going for. It's not normal. And there can be problems because patients can become enamored of that effect. And for those patients who are actually prone to addiction, it can trigger addiction. But even patients who don't intend on taking their medications recreationally, those who follow their doctor's instructions, can be mistaken about what the point of taking that medication is and how it's supposed to, quote unquote, feel. More on that later. And it's the same for sedatives. For people who have anxiety, they take anxiety medication. And here I'm not talking about SSRIs and SNRIs and other medications often called antidepressants like Prozac and Effexor that take a few weeks to really begin to work. I'm talking specifically about sedative hypnotic agents like Valium, Xanax, Ativan, Klonopin, etc. So patients feel anxious. They take a sedative, and the first time they take it, the medicine does more than just calm their nerves. They feel mellow, they feel tranquil. They suddenly feel a sense of well-being wash over them, that everything's going to be okay. Not just about what they were worrying about, but everything is going to be okay. And that's not normal. That's overshooting. And doing that is unavoidable that first time, those first few times. Just like with the stimulants, just like with Adderall. It's the same reason some patients experience actual sedation those first few times. We don't want to make the patient sleepy. We've overshot. But even using the lowest dose of Xanax, 1/4 milligram, sometimes makes the patient feel a little sleepy when they take it for the first time for anxiety during the day. Today, I'm here to talk about Xanax in particular and how among all of the benzodiazepines, Xanax is the favorite. By far. People like it. And addicts love it because, unlike the others, it gives a sense of well-being that goes above and beyond even what's typical for this class of medications. And certainly it has something to do with its molecular structure. We haven't really elucidated the reasons why a particular medication feels a certain way or has a certain unique effect compared to the others, because Xanax has the same basic pharmacodynamic profile as the rest. They differ in terms of pharmacokinetic profiles, in terms of how they're absorbed and metabolized and how they're cleared from the system, their half-lives, how long it takes the liver usually to convert it to a form that can be excreted. That's pharmacokinetics. But in terms of how it activates benzodiazepine receptors, the pharmacodynamics, they're all the same. Allosteric modulation, which you can learn about in my 2-part series on the benzos. Please check that out. But as a clinician, one can see over and over again that Xanax is the favorite. And by the way, what I'm going to tell you today is anecdotal. These are anecdotal reports based on my own direct observations through the decades. I've been in practice almost 30 years. I've seen tens of thousands of patients in all settings. And so while I can't claim that the information that you're going to hear today from me is scientifically validated, that there's research to back this up, I guarantee you that what I'm going to share with you today, you can rely on it. It is real-world evidence, at least in terms of my own experience. And so I'm going to ask you to trust me on this. I'm not going to make any definitive claims that aren't backed up by my own experience. So Xanax is the favorite. It takes the crown, but Valium is also favored by patients. And that might be due to the molecule's lipophilicity. Diazepam is very lipophilic or fat-loving. And the implication there is that it dissolves easily in fatty tissues. As a result, it crosses the blood-brain barrier a little faster and a little better than the others, reaching the central nervous system faster. And that may account for more euphoria than some of the others. So that may be, I'm speculating here, that may be a reason why patients kind of like Valium. Midazolam is also highly lipophilic, but Versed is mainly used in institutional settings like hospitals and dental offices, and it's usually given intravenously before operative procedures. Clorazepate, brand name Transine, is the other one. Regardless of lipophilicity, and Valium is more lipophilic than Xanax, the latter definitely carries more euphoria compared to the rest of the bunch, and a lot of patients, even the ones that don't suffer from sedative hypnotic use disorder, will take it, and then maybe I'll switch them to Ativan or Klonopin for some unrelated reason. Maybe we want the longer half-life, or there are concerns about the liver. And a lot of patients will tell me that they want to go back to Xanax. Xanax felt better. And what these patients don't understand is that what they're seeking when they ask me to do that, whether or not they realize it, is euphoria. Not the absence of anxiety, but the presence of a sense of well-being that goes beyond the mere absence of anxiety. Everything's going to be okay for the next couple of hours. Because I guarantee you, Ativan and Klonopin and the others block panic attacks just as well. They diminish anxiety, they stop what patients call racing thoughts just as effectively. Racing thoughts are actually a symptom of mania, but that's what patients will say when they're talking about anxiety. But here's the deal. You're supposed to take enough medication so that you don't have the symptom, be it anxiety or panic or insomnia, whatever you're taking the tranquilizer for, because these are tranquilizers. You just want to block the symptoms. And while the first time you take it, you're going to get that supratherapeutic effect because you're uninitiated and you have zero tolerance. And so you're going to be maybe a little sleepy when we don't want to make you sleepy if it's during the day and we're trying to block anxiety. That doesn't always happen at the very lowest doses, especially not if you're walking around, staying active, and you may not even notice it. But by the same token, you're also likely to experience a profound sense of well-being that is partly relative, at least partly due to the sudden absence of symptoms of anxiety, okay, but also something more. You're more relaxed, not only than your norm, but than everyone else's. A supratherapeutic effect, which is hard to avoid. Euphoria. And patients who are prone to substance abuse and chemical dependency, especially those with alcoholism and those whose drugs of choice are downers, will strive for that euphoria, whether or not they're trying to take the drug recreationally in their own minds. Often, innocently enough, patients will confuse those early feelings of euphoria with the intended therapeutic effect, which is simply the lack of anxiety. And as a consequence, if they're working with an incautious provider especially, they end up on ridiculous doses trying to recreate that feeling. These patients will come back and they'll tell me, I don't think it's working. It's not working. I don't feel anything. And I'll ask, what do you mean you don't feel anything? I don't think it's working. I can't feel anything. And I have to explain to them, you're not supposed to feel anything. You're supposed to feel normal, which is just calm, the absence of anxiety, not mellow. Patients develop tolerance to the euphoria and they want to increase the dosage unnecessarily, or they want to go back to Xanax. Again, for no better reason than to recreate a feeling. But you don't have to be a drug seeker to fall into this trap. That feeling that patients are seeking when they ask me to switch them back to Xanax, that's not necessary. These patients are chasing a side effect, whether they know it or not. But if they're not counseled about this, how could they know it? Except for the ones trying to abuse the medication or trying to manipulate the prescriber. There are, of course, those patients, those who are trying to get high. But the difference is those patients also take more than what's prescribed, and they run out early, and they try to fill their prescriptions early, and they lie to their providers. But that's not what I'm talking about in this video, okay? And I want to make this very clear. I'm not talking to those of you out there who you know who you are, and you know why you love Xanax, okay? I want to help everybody, but this video is about spreading a message of insight. My hope is that this message will go out to those of you who don't know the deal and who innocently are treading on potentially shaky ground. I had a viewer, a friend of mine actually, who saw the first version of this video that I posted about a year ago, and he, quote unquote, took umbrage, he said, somewhat jokingly, but actually not. He took umbrage to the idea that he's chasing euphoria just because he takes Xanax during the day, pretty much every day, and benefiting from that very real but very transient sense of well-being. Xanax and the benzodiazepines, they're band-aids. Their effect only lasts a few hours. And Xanax is very short-acting. And so when it wears off, a lot of times people are in a rebound state where they're seeking more. But that's not what I'm saying. I'm not saying that every patient who uses Xanax during the day on an as-needed basis is abusing the medicine or taking too much of it or taking it for the wrong reason, if they're like my friend. I'm simply explaining why some patients end up on very high doses they don't need and why patients might prefer Xanax over the others. And it's because Xanax is the king of well-being. It beats them all. Can't tell you how many times patients have asked me to switch them back to Xanax. Patients don't ask me when I switch them from Ativan to Klonopin. They don't ask me to go back to Ativan. And then the patients who are blatant drug seekers, overt drug seekers, they're always on Xanax. And they're always wanting a prescription for Xanax. And they are invested in Xanax. And that's a litmus test that you can tell that they're drug seeking when they want one benzodiazepine. They're not happy with just any old benzodiazepine. No, they want Xanax. And then when you ask them how much they're taking, they give you some ridiculous dosage that nobody would ever prescribe in a million years. That's not what I'm talking about today. So while patients develop tolerance to both euphoria and sedation, actually limiting their use for insomnia because of that, there's no tolerance for blocking a panic attack. This is important. If you take, let's say, a 1/4 milligram of Xanax, the lowest dose, to stop a panic attack and to calm down, and then later, after you've been taking Xanax for a few weeks, you need to take a slightly higher dosage to calm down because you've developed tolerance. That's possible, that's reasonable, but that's it. You don't need to keep escalating the dosage. It might not, quote unquote, feel the same, but it's not supposed to feel like anything, including the way it might have felt at the beginning. But I guarantee you, you won't be panicking. Sure, there could be residual anxiety, and maybe patients with a lot of performance anxiety, say, who feel very uptight, they might need to raise their dose before a speech or take an extra dose before they go into a meeting, or those with social anxiety before they go to a party. If they're really worked up, fine. But those individuals won't be panicking on a milligram of Xanax, and it's not going to take 3 milligrams of Xanax to calm someone down. There are patients who tell you that they're taking a milligram of Xanax 3 times a day, and when you ask them, well, how often do you have a panic attack? Every day. Well, how long does it last? All day. They're panicking every day, all day, on 3 milligrams a day of Xanax. There's no way. There's no way. And patients who make those absurd claims, they are being dishonest. I'm not saying they're all addicted, that they all have sedative hypnotic use disorder, but they're not being honest with themselves if they tell you that. And it isn't going to take 3 or 4 milligrams of Xanax to stop a panic attack. It might take 4 milligrams to stop a person from going into withdrawal. That's not a panic attack. That's you're about to have a seizure. That's one thing. And you get there on these high doses from which you have potentially life-threatening withdrawal because of dosage escalations that go far beyond the therapeutic effect. You get to a point where you're as relaxed as you're going to be, then any more relaxed and you're overtly intoxicated. And then if you keep just piling on the gamma aminobutyric acid, that's the inhibitory neurotransmitter in the central nervous system that is increased, the actions are increased when you take benzodiazepines, eventually someone will fall asleep, even if they have super high tolerance. But they stopped panicking a long time ago. We didn't have to take it that far where they were dysarthric, they were slurring their speech, or where they're going to have a blackout, anterograde amnesia, because you gave so much. It's just like alcohol. You don't develop tolerance. I'm going to say this again. It's so important. You don't develop significant tolerance in the context of treating high anxiety. And no tolerance at all beyond a certain dosage, in my opinion. This is not something that I learned in medical school. This is something that I came to the conclusion of myself prescribing the medication over and over again, thousands of times. And I've also taken Xanax, and it's not my drug of choice. I'm in recovery, and my drug of choice was always the uppers, the stimulants. I wasn't big on the downers. They just made me sleepy and put me to sleep. I always said I want to be awake for my party, and I want to be asleep. But there are some people I remember a friend of mine, we were going to go out to a club, and he took a 2 milligram bar of Xanax, a 2 milligram bar, and he was ready to hit the town. And I just thought to myself, a 2 milligram bar, and I would be prostrate. I would be asleep, deeply, deeply asleep. Tolerance, but also he was hardwired in a different way because he was also an alcoholic. He also drank too much. There's cross-tolerance between alcohol and benzodiazepines, and so it makes sense that somebody who loves alcohol would love a sedative, would love benzodiazepines in particular. When I would take a benzodiazepine, I didn't feel much euphoria, including the Xanax. I don't remember ever feeling much euphoria. So some people are just hardwired differently. But those patients, even those that don't have alcohol use disorder and those that don't have sedative hypnotic use disorder, if you're wired in that way that Xanax just rocks your boat, then you are still at danger of overtaking it innocently enough. And if you're working with a provider who doesn't know what they're doing, ending up on doses, and now that dose that you're taking every day, now you have to take it. Now it's a liability. You have to be weaned off of it, or you're going to have, if not frank withdrawal, you're going to have rebound anxiety that's worse than the anxiety that you had when you started. You don't develop significant tolerance to the medication's anxiolytic effect beyond a certain dose, the anxiety busting effect. It's impossible to be having panic attacks all day long on that much Xanax. Either they're drug seeking, or what they're calling a panic attack is not a panic attack. And so maybe we need to go back to the drawing board and define terms and say, what are you calling a panic attack? But the euphoria, you do develop tolerance to fairly quickly, and that's how patients end up on these high doses that place them at risk for withdrawal, which can be life-threatening. But a little bit goes a long way as far as anxiety is concerned. A lot of patients are chasing euphoria when they want more or when they reject another benzodiazepine in favor of Xanax, when that's not the goal of treatment. It's a supratherapeutic effect. Not a super therapeutic effect, a supratherapeutic effect. We're going beyond what we really want, what we need. We're overshooting, and that tends to happen at the beginning. And that's not therapeutic at all. As the dose is escalated by some practitioners higher and higher, rebound could induce a grand mal seizure, so it matters. Practitioners should know, especially you practitioners in training out there, you should know that Xanax is not like the others. Now, there have been studies that have looked at Xanax's potential antidepressant action. There was at least one study that reported positive findings, but research has shown mixed results overall. It hasn't been reliably reproduced. And I wonder if those so-called antidepressant actions were due to Xanax's particular ability to induce this mild euphoria. Who knows, but the findings have not been consistently replicated. It's not a medication. I would not ever recommend Xanax monotherapy as antidepressant therapy. The other thing that patients don't understand is that when we overshoot, whether they're sleepy or whether they're just very mellow and relaxed, that's intoxication. They're intoxicated. It may be mild, but that's what it is, even if their intention was not to take it recreationally. So even though they're not slurring their speech and they're not falling down and they're going to remember everything tomorrow, if they have that sense of well-being, if it's intense, they're mildly intoxicated. They're definitely disinhibited, which can actually be useful for social anxiety and performance anxiety. But when they're on an unnecessarily high dose, that disinhibition can lead to poor judgment. A person can be inappropriately expansive. They might say things that they wouldn't ordinarily say, reveal things, for example. They might even have cognitive deficits. Their short-term memory may be mildly impaired, which is the last thing you need going into a presentation or a meeting. So patients should understand this about taking a little bit extra, a little bit more than maybe what they need. If they're going to risk overshooting a little bit, then maybe just take a half. And then maybe take propranolol for the sweating and the shaking. But I have a great video on performance anxiety. Please look for it. It has very few views right now. It's one of my better videos on anxiety. When the medications are prescribed for insomnia, a lot of people will take them in the early evenings. Again, innocently enough, in preparation for bed. But that's not the best way to take a sleeping pill. And again, I have a whole separate video on how to take a sleeping pill, so please check that out. But for many of those individuals, they come home from work, and these are people that aren't abusing the medication, okay? But they come home from work, and instead of waiting until bedtime, they'll take the medication to wind down. Like other people might drink a glass of wine around dinner time. And the reality is that just like that cocktail before dinner, what they're doing is intoxicating themselves, just very mildly, as a reward for a long day, to feel better. There's that word again, feel. So it's not that they're anxious. So as a reward, to prepare for bed, to prepare for their wind down, a lot of people will have a drink. And we wouldn't consider everybody who has a glass of wine before dinner, we wouldn't consider all of those people alcohol dependent, or we wouldn't say that they're abusing alcohol. And similarly, a patient might take their Xanax hours and hours before bedtime for the same reason. And we're not going to say that those patients all have sedative hypnotic use disorder or that they're abusing their medication. But my point is that they are intoxicating themselves very mildly, just like the patient who drinks that glass of wine. Now, before people get up in arms about my use of the word intoxication, okay, semantics can get us into trouble. If you're getting defensive about the fact that I'm using the term intoxication to refer to drinking a single glass of wine around dinner, and you're one of those individuals who does that, you might take umbrage, like my friend, and say, wait a minute, what are you talking about? I'm not intoxicated at all. It takes more than a glass of wine to intoxicate me, believe me. Those of you who are habitual drinkers of wine with dinner. But my point is that feeling that people feel when they have their glass or two, however much it takes, that feeling, that euphoria is intoxication. And there are different kinds of intoxication. You can have intoxication from lithium. So please don't get hung up on the word intoxication. It's simply a clinical term that I'm using clinically. I'm not using it colloquially. The problem is that the first time patients take these medications, they feel mellow, they feel calm, wow. And Xanax is really wow. And they like it. And they think this is how I'm supposed to feel. But they're more relaxed than normal. And they're not just not panicking, they're slightly intoxicated those first few times. Taking the dosage as prescribed, a low dosage, just exactly as prescribed, a single dose can do it, especially the first dose. And it doesn't happen to all patients, but one has to educate them when it does happen. Patients will actually say to me, I don't feel it anymore. And that's precisely the goal. That's exactly what we want. They shouldn't have felt anything in the first place, but it was unavoidable. It was unintentional. We want you to feel nothing. No side effects, no anxiety, just normal. And just to be able to go about your day instead of waiting for the feeling, which is what a lot of patients do. Ask yourself, is this how you're taking Xanax? If you're taking it and then you're waiting for some feeling to kick in, you're waiting for euphoria. If you're waiting for some feeling that you're not already feeling, then you are waiting for that supratherapeutic effect. Just like some patients do with their stimulant medications for ADD. As opposed to not taking the Xanax until you feel a symptom and then dosing and waiting for the symptom to go away. It's one thing if you're just like, you're a nervous wreck and you just don't want to go in and give the speech, or you don't want to go to the party because you're feeling way too self-conscious, or you're having a panic attack, you're having trouble breathing. If you're waiting for the symptom to go away, that's one thing. But if you took it when you didn't really need to take it, you were feeling fine, but because the bottle says you can take it up to 3 times a day, and you've been doing that since the doctor prescribed it to you, and you don't think you're doing anything wrong, but you're really fine, you haven't scrutinized, well, do I need it? Do I need it? It's daytime, it's a tranquilizer. It's as needed, not just maybe at the beginning, your doctor told you go ahead and take it prophylactically to prevent anxiety. And so a lot of patients have the blessing of their prescribers to take it that way. And I've prescribed it that way, especially to a certain subset of patients with severe endogenous anxiety, who are more or less truly anxious all the time. I mean, all the time, patients with generalized anxiety disorder. But if you're supposed to take a benzodiazepine on an as-needed basis, if you take it and you haven't really scrutinized whether or not you absolutely need it or whether you could hold off, and again, ironically, it's those patients who most need it who will hold off or because they're afraid to take it. But if you're then taking it and you're waiting for that euphoria, ask yourself, what am I waiting for? How am I feeling? How was I feeling 2 seconds ago before I took that pill? It's going to take you at least 10 minutes to absorb it. It's euphoria, folks. For a lot of people, it's euphoria. And maybe it doesn't apply to you. Maybe you're not the person I'm talking to, but ask yourself. If you are on medication, Xanax or Valium or whatever benzodiazepine you're on, you owe it to yourself to ask yourself, am I waiting for euphoria? Euphoria, which is very tricky. It's difficult to get away with feeling euphoric for any length of time because you can't stay up there. Eventually, the euphoria dissipates. And the more euphoric you feel, the more liability there is for a rebound dysphoria. Perhaps worse than the original feeling. and especially if you were feeling fine when you took the medication. I'm not talking about all cases. I have patients that I tell them, take your Xanax every day and take it 3 times a day. And I have to tell them to take it because they're loath to take it. So I'm not talking about all patients, okay? But expectations are important, education is important, and if the anxiety is that bad, then you should also be on a serotonergic medication. If you need round-the-clock Xanax, then you should be on an SSRI or an SNRI. A lot of times we see these patients and they say, oh, I can't take those. It made me feel like a zombie, or it made me feel worse, or I had more anxiety, and they rule out entire classes of medications because they had a bad experience or because they really didn't give those other medications a chance. And a lot of times it's the benzodiazepines that actually sabotaged those trials because the patients get distracted by the way that these Band-Aids work, how they work very quickly and they overshoot and they give us that euphoria at the beginning. And then we chase that side effect. And well, what about the Prozac? Oh, no, I know. I hated the Prozac, hated it. Because it made you nauseated, or the Zoloft, because it gave you diarrhea and you didn't wait it out. You didn't talk to the provider. The way I dose it, I try to avoid the diarrhea altogether. And I'm able to avoid it altogether in the vast majority of patients because I dose it properly. But I work with the patient, and if they do develop diarrhea, then I tell them to take Imodium. I mean, we get past it so that we can get to the good part. Just like these videos. People drop out way too early. Anyway, that's enough. Thank you for listening to me. As always, questions and comments are welcome.